So Dr. Faris Alaji is Associate Professor at Qatar Biomedical Research Institute, and he will speak about how to optimize the collaboration in precision oncology between the countries, a regional consortium. And sorry once again for that.
It's okay, it's okay. Thank you for the introduction. So like, I'm a senior scientist and at the QBRI, Qatar Biomedical Research Institute. Thank you all for the attendees, and also thank you, Dr. Fadi, for the invite. Now, the question here is slightly complicated about how to do regional consortium. I will start by describing exactly what we're doing in Qatar, and that might be the pathway to a regional collaboration. Now, there was a lot of interesting talks and discussions, and especially the last one with the AI and also the previous cases. And I think definitions is a problem at the moment with precision oncology. So I don't think precision oncology is personalized medicine. They're not anonymous. Modern medicine, particularly oncology, has always been personalized. So personalized information for each patient on the TNM staging, tumor histology, a lot of biomarkers. It's routinely used to decide on the treatment for patients. So when you look at the definition of precision medicine, the NIH defines it as an approach for disease treatment and prevention that takes into account variability in genes, environment, and lifestyle. So the multiple factors going in there. And then, unfortunately, and I've heard it in this talk, this has been hijacked by another field called genomic medicine, which is using genomic information in the treatment planning or the clinical care of patients. And that is really a problem. And this is good that the previous talk was talking about, and Dr. Fadi as well mentioned, that there are more information for different molecular levels. And genomic medicine is not synonymous to precision medicine, which is not synonymous with personalized medicine. And really, when you look at it from a biology point of view, my area of cell biology, it's actually, we come from one genome, and that gives us all the complexity moving forward. Let me just put the laser. We move from one single genome to highly specialized functions and organs. And this is going through a complex molecular interplay between many different things to actually go from the genome to cells with functions that go into tissue. Cancer is not different. It's the same. It's actually more complex because the genome is not very stable in cancer. So, when you look at this, I would prefer to change the definition if I was allowed and call it about molecular variability. That's what we really need to look at. It's integration of DNA, RNA, protein. One day we'll be looking at metabolome, hopefully sometime soon. So it's much more complex. And the question now becomes, why do we need precision oncology if we agree with my definition? And one thing that's missing in the definition, and a lot of people don't touch on this point, it's a key word in the terminology, it's precision. So it's, for me, precision oncology is about getting precise about the treatment. And if you look at any standard survival curves from any cancer, and I'm talking about primary cancers, not metastatic stage, these survival curves, they show the average for a group of patients, let's say, any subtype that has the same clinical pathology treated in the same way. These graphs hide very important information. We have patients who survived or patients who didn't. So if you split this heterogeneity is hidden in that average graph. And even with patients that have an event like metastatic event, recurrence event, or death from the disease, the time that they benefit from the standard of care differs as well. So you have patients that respond for about 10 years and then they have a metastatic relapse or something, and patients who die within less than 3 years. So clearly there's a lot of different outcomes in the patients. And even when we look at a new drug that may improve survival by 20–30%, we are going from the red line to the green line here, but we still have heterogeneity. Not every patient who received that treatment is responding. And this is the problem. And really, we need to get more precise and accurate about predicting the benefits from treatment. Now, for enemy here are heterogeneities. And it's not one heterogeneity, there are many. So there are heterogeneity at the biological level, clinical level, and the personal level. At the biological level, we have the cellular and molecular heterogeneity, but of course, we cannot forget the tumor microenvironment. So we generally take bulk of the tumor, lyse it, collect DNA and RNA, and profile, but this is not how the tumor operates. There's immune cell infiltrates we cannot ignore, for example. And of course, sample quality and data quality is very important when we look at the profiles, but we have to remember that whenever we do profiling, we're looking at a snapshot from the biopsy or from the tumor, resected tumor. And this is not really how tumors work. They are very dynamic. They evolve very quickly. And we also cannot ignore the effect of treatments on the dynamics of the tumor because it changes it. Lastly, we have the personal heterogeneity. This lifestyle and maybe sometimes mental state could affect treatment outcomes. But the more obvious one is adherence to the treatment. For example, for breast cancer, we are assuming that the woman is taking tamoxifen pill daily or for up to 1 to 5 years. I mean, we don't know that for sure, really. So there are a lot of heterogeneity to deal with. And if we deal with this heterogeneity, I believe we can start approaching precision medicine. Now, the issue is, how do we do that? And this is where we need the model to figure out how to do precision oncology, and on a larger scale. I mean, case by case, it's very important, but for healthcare system, there's something bigger, and this requires paradigm shifts. We need to move away from, move into dynamic integration of diagnostics, therapeutics, and include biomedical informatics, which includes bioinformatics and medical informatics. And this is where AI might help a lot, because the amount of data is insane from coming out of all of this. We need to also move from average efficacy of treatment to the individual benefit. How does this patient benefit? So become more patient-centric. And as I mentioned once previously in one of my comments, that we need to move from ad hoc treatments when we see at the time of progression to actually do all this profiling at the time of first diagnosis and understand the tumor. And sometimes we do have to repeat the profiling, unfortunately, because the tumor is dynamic, like I said. Now, this is not easy, and it requires investment and funding. But I really believe that with time, this will allow more saving, because you have less free hospitalization, less free treatments, and more alleviation of the burden of disease. Now, for my part is the research side, I really try to cover this area, going from diagnostics to therapeutics. We stay closely to the clinical side with clinical samples. That's where the research is happening, is starting, and we hope to move things towards clinical practice. So we always deal with the clinical collaborators closely, because that's where we will try to keep it. Now, I don't want to talk about my research, but just to mention that I have recently moved to Qatar. It's actually not recent. It feels recent. I moved just 2 months before the COVID pandemic, so I've been in lockdown for about 15 months. So I'm really just now starting to gear up into work. Now, I'm building the Translational Cancer Research Group. And I moved from a Western biomedical research system from Australia. And coming to the region, one of the first questions I had was, we need to identify areas of unmet needs locally, because there's a lot of innovations, a lot of profiling happening for overseas tumors, Caucasian mainly, but ethnicities might play a role here. So we're missing this. And the other building block that I'm working on is building collaborations and networks. Now, by doing this, we can tailor research. And I'll just very briefly describe here the sort of programs we're running. So we have a first program that is it's called the IDRP, so Interdisciplinary Research Program. This is for our entire center, so all the research groups in the center collaborate and work on this. And we're collecting prospectively breast cancer samples from the Hamad Medical Corporation, so that's the main hospital health provider, national health provider in Qatar, and also in collaboration with King Hussein Cancer Center in Jordan. So this is actually trying to look at multi-omics. We'll be looking at multi-omics, DNA, RNA, protein, blood, tumor, and looking at genomics, transcriptomics, and proteomics, and metabolomics as well. And this is to go into really characterize regionally what kind of cancers we see. So we will have Qatari and Arab populations here. Now, my lab will also be leading this kind of work of doing the same analysis with the Cancer Genome Atlas data and trying to do comparative omics to actually find what's similar and different in Arab tumors and others. Now, this will allow us to also tailor our clinical research to the region as well, based on biomarkers and based on experiences we see here and based on profiles we see here. This is also including generating our cancer cell lines, breast cancer cell lines from the region here. Now, for my talk today, I'll be talking about the first and last point. And the first one I'll be very brief about it, because the second point I think it's more relevant to this talk. But the other thing we've started on building now is the Qatar Precision Oncology Diagnostics project. And this is actually digging back and leveraging archival tissue for retrospective profiling to carry out targeted panel profiling, DNA, RNA, and protein. And I'll explain that in more details. Coming again to the region, my first question was, we need to figure out priorities. And this is, I'll go very briefly with this because that's not really the point, but there's a message from this. The first thing to do was to actually look at cancer incidence in the Arab region. So I've analyzed using the global cancer data for 2018. Looked at the incidence of cancers in the region for females and males, for all groups, for age-specific groups. And in females, we found that 5 particular cancers have higher age standardized rate than the global rate. These are breast, liver, bladder, Hodgkin, and non-Hodgkin lymphomas. For males, it was the same 4 cancer, of course, not breast cancer, have higher incidence rate than global rate. Now, one thing that got my attention is that mortality to incidence ratio, which is not a surrogate for survival, but at least gives us some indication about mortality to compare across regions. Compared to the global MIR, we have a lot of examples of cancers that have higher MIR for the Arabs than the global MIR. This suggests a scope for improving treatments. And when we look at age-specific trends, high liver cancer incidence in both sexes over 30 in the Arab region are really driven by Mauritania and Egypt. And this is in fact preventable. This is mainly due to cirrhosis, due to prevalent hepatitis C infections that are not treated very well in these areas. Another point of interest was cervical cancer. And you can see that it happens at all ages, but particularly its Northern African countries have high incidence of these cancer. And again, this is preventable through vaccination to fight the prevalent HPV infections in these areas. Now, thyroid cancer was another interesting cancer. It has high incidence in many Arabian Gulf countries and the Levant in females. And this is suspicious because this could be linked to some genetic syndrome, and we don't know this. We don't have information on this. The next cancer, childhood cancer, so for children under 15, there seems to be high incidence, higher than the worldwide ASR in young girls and boys. And for NHL, for example, this could be linked to hepatitis C, but we don't have evidence for this. But again, the high incidence in these blood cancers make you suspect some genetic cause. Finally, for breast and ovarian cancer, it seems to be affecting younger women, particularly in the Levant, Lebanon, Syria particularly, and then followed by the Northern African countries. And you can see some sort of increase of ovarian cancer. So this is suspicious of hereditary breast and ovarian cancer syndrome, Hedgecock syndrome. And if you look at BRCA1 and 2 studies in Arabs, they exist, but it's not comprehensive enough. And looking at pancreatic cancer, it also seems to affect younger females and males. Again, it's the Levant and the Northern African countries. So this again could be related to Hedgecock, but it also might suggest that there's more BRCA2 mutations than BRCA1. And also there could be a lot of mutations in other DNA repair genes. Now, just to summarize this part, the Arab region does seem to have different cancer trends than other places. There may be a lot of genetic factors, and this could be a lot of marriages of close relatives. But to come back to the point of this event, so apart from tailoring screening and prevention strategies, treatment might be needed. For example, if we know that BRCA1, BRCA2, or DNA repair genes are highly mutated in the particular cancers we see, then we might need to start looking at using cisplatin and maybe with PARP inhibitors as a first-line therapy rather than doing second-line therapy. So that information is very important. And this brings me to the second part, which is more relevant, is the Qatar Precision Oncology Diagnostics Program, QPODEX. And in here, we're not taking a whole genome approach yet. So we're planning to do that prospectively study. But in this retrospective, we want to dig back into the FFPE archival tissue. And we want to target certain panels that we know that have clinical actionable information that the MDT might find useful. This includes TMB and MSI, which were mentioned before, cancer mutations and cancer driver genes. We want to look at molecular subtyping of cancers, look at spatial profiling by multiplex IHC, and of course, looking at predictive signatures. So it's sort of similar to what the previous presenter from CARIS was talking about. The point of this is to actually figure out, from the cancers we see locally, are there different trends? Are there different molecular profiles? And eventually, what we hope to do is include this in part of molecular pathology. So a biopsy is actually profiled with 3-dimensional, 4-dimension, whatever dimensions we can get, to get the most amount of information that would help the MDT to make a decision for that patient. So in case if you can predict that standard therapy will work, example, chemotherapy, radiotherapy, that's great. In case we predict it's not going to work, this is when we start thinking that we need to start thinking of other therapies as targeted therapy and immunotherapy, for example. Now, tumor mutational burden, this was mentioned before, and I'm not going to spend too much time on this. The major point I want to say from here, 2 points. The first one is this landscape is based on Caucasian tumors. We have no idea how the Arab tumors look like, because who knows, we may have high TMB burden for a lot of cancers. So we know that all the cancers sit in this region. We don't know the landscape in the Arab region, Qatar or the MENA region. And also TMB is not the only marker for immunotherapy. PD-L1 expression, tumor infiltrates, there are other markers for immunotherapy benefit. The missing data here is that we don't have cross-sectional data on TMB, TILs, molecular profiling on a large scale for the population to understand what really should work for us and what areas should be filling in terms of diagnostics links to therapeutics. This is another example looking at the mutational patterns for breast cancer and the molecular subtypes for breast cancer. And I mentioned this before that PIK3CA mutations have been recently got FDA approval for treating refractory ER-positive breast cancer. We don't know how many of the breast cancers in the MENA region have PI3K mutation. And from a health point perspective, to start making the case that we should invest into this, we need that kind of information. And again, similar thing with the molecular subtyping, the PAM50 subtypes. And apart from them being prognostic, there's a test based on the PAM50 subtypes, the Prosigna, which works similar to the Oncotype DX, and it avoids chemotherapy for patients that have low score. Now, I don't know if this is the same in other countries, but the breast cancer MDT in Qatar sends some samples to the US to do Oncotype DX. That's a $5,000 test. We can do something similar here. But the message from all of this is that the mutational and molecular landscapes of cancers in Qatar and the MENA region are unclear. So the vision here is that cancer omics have provided a lot of information about heterogeneities and how to deal with them from a clinical perspective, not just research. But all of that information is based on Caucasians, which may be very well different from the cancers we see in Qatar and the MENA region. And our strategy was to form this alliance between the different stakeholders, including, like what I mentioned, Hamad Medical Corporation. This is the National Cancer Care and Research Center that treats most of the cancers, maybe all of the cancers in Qatar, and 2 research institutes. And what we want to do is to test and evaluate clinically relevant molecular profiling of cancer tissue in Qatar. Our study is in 2 phases. The phase 1 is a retrospective study. So like I mentioned, we will start with 6 cancer types. And we plan to do 2 things. First is next-gen sequencing to look at tumor mutational burden, MSI, and cancer driver mutations. And we actually now deciding to include more panels. I'll come to that in the next slide. And we also want to look at the microenvironment profiling. This includes 2 things. First, the multiplex IHC. We're using the Mantra system where we can move to more clinically relevant platforms. And we'll also be looking at bulk profiling for cancer markers, cancer pathway, and immune pathways. So the information from this is to actually look at the immune pathways and signatures and immune infiltrates alongside with predictive and molecular subtyping at the mRNA and protein, and link all of this for the same case with the mutational and genomic information. Strategically, we are leveraging a lot of resources invested in Qatar, and Qatar has done great in investing in the infrastructure to run all of this kind of things, to test molecular diagnostics and see which ones are meaningful and which ones that inform more policy making and more actually clinical practice. The other part is translational outcomes from the retrospective study, because we have the survival information already. We can associate the molecular landscapes we see with patient survival and start finding, the patients who did not respond to the standard of care or whatever treatment was given to them, why did not respond, and could we have predicted a different treatment, such as immunotherapy or targeted therapies. Now, the clinical outcome is to start, we want to generate data that support the clinical and business case, to start including some of these tests and routine practice. It might be too expensive to run it for every patient, but I would argue that we should run it to every patient from the beginning. And I think I mentioned this point before. After our retrospective phase, we want to look at starting to work prospectively. I mean, we can expand to include other cancers and hopefully cancers from other Arab countries eventually. But one of the main issues, and was touched on with the case reports before, especially when you start running this in a hospital system on a routine basis, is the pathway for running and reporting the tests timely to the MDT, and also not swamp the MDT with information and they're lost about what to do. Sometimes even AI, I would say, could get lost in what we should be doing. Now, this is a big project, and to actually get it working, we have a big team involved, and we're still working on the team structure and team memberships. But it's organized in the way that we have a steering committee, cancer-specific teams, and we have support teams, and of course the funding. The steering committee team is led by Dr. Mohammed Salim. He's the medical director of the NCCR in Qatar, and we were lucky with his great support and vision. And he bought into this concept straight away from the first presentation, because it really sits with the agenda and the vision for the NCCR. It's called Mustashfa Al-Amal Bil-Arabi. The way we organize it is that each team is led by the clinical lead that formulates different groups. So we're almost done. We just need to finalize these two groups with the team members. So the teams would include subspecialties who are experts in the area of the cancer we are really looking at. Now, from the funding part and the support, so Qatar Foundation, which is my employer, have started the Qatar Precision Medicine Institute. This is a new entity with a new vision, which is to move precision oncology from research to practice. And it's going to be an enabler for this kind of development. So we have presented this proposal to them, and Dave Brown, the Science and Programs Director, he comes from Genomics England, and he's moved to Qatar to lead, and he's almost the architect of QPMI operations, like what to do. They bought into this project, so luckily we're going to get the funding for this. And it was also offering to do whole exome sequencing, because we might discover genomic mutations that have high prevalence here that could be actionable, but they're not usually seen in other places. And the other part is to include Foundation 1 panel, because the QPMI has multiple agreements and MOUs with industry partners, including Roche and Illumina. So we are looking at including the Foundation 1 panel in parallel to the Illumina one. So, sorry, just a second. Now, I'm not sure how am I looking for time. I might skip these, just basically what we're expecting. So what we're really expecting is to start looking at molecular subtyping of cancers in a clinically relevant way. For example, for colorectal cancer, we know that molecular subtypes have different mutational and immunogenic profiles, and they would respond differently to different treatments. And it's important to know how do we have similar percentages of colorectal cancer subclassification in Qatar and Arabs or not? And immunoscore is another thing we're looking at testing. Same thing with bladder cancer, molecular subtypes differentiate treatments, and this actually provides benefit from immunotherapy. So again, we're really trying to draw the same picture that's drawn for Caucasian cancers. We want to draw it for the Arab region, and this information is missing. And same thing with endometrial cancer, molecular subtyping that has different outcomes, and we can look at eligibility for immunotherapy based on TMB, PD-L1 expression, but also another profiling of mutations and also markers. And last, cancer. Sorry, I'm skipping through this. It's just we've probably covered a lot of these topics already. Thyroid cancer, for example, is prevalent in Gulf countries, including Qatar, in females. And I think most thyroid cancers are easily treated, which is the case. But you get some types of papillary thyroid cancers and also other types of thyroid cancer undifferentiated. They don't respond very well. And recently, it's been shown that there's a subset of thyroid cancer that has high TMB, it expresses PD-L1, and has BRAF mutations. So these may be candidates for immunotherapy, which is unusual for thyroid cancer, but it could be that the thing that we have to do. Now, to answer the questions about how do you move to this information to the clinical tumor board setting, molecular board setting, this is has been covered. It's just that you need to see a report with actionable molecular data backed by clinical evidence, easy to interpret. I would say, prognosis for standard of care should be provided, because if the prognosis of standard of care is going to be not very good, we need to provide prediction of alternative, more precision oncology kind of treatments that, based on the molecular profile, we predict it should be the treatment. and suggest an optimal treatment in a clear way that doesn't confuse the clinician. Unfortunately, we cannot always promise that, because when, I work a lot with whole genome and whole transcriptome profiling. Sometimes I get lost and I think I know a lot of things. It's not easy. This is where AI is needed. Now, if this is our target, the path to this, we need to integrate molecular pathology into routine pathology. And this might be costly, but I think it will have cost effectiveness and reduction in the future. And maybe with the panels we can discuss this. And we also need the framework for timely and meaningful data reporting. And these two center stones of doing precision oncology has a lot of background behind it. We need to keep our interdisciplinary collaboration in the clinic, pathology, at the research side. And this has to be very dynamic, and we need to always continue learning and education, because information comes out about drugs, mutations, new tests, and so on. And I would say, importantly, we need the dynamic clinical research environment, because we need to keep evaluating the relevance of new information, new diagnostics that come out, particularly, I would argue, for our own patient population in the Arab region, because we are absolutely underrepresented in any international omics study. We also need to generate local evidence and experience to demonstrate capacity to enable, and data to enable cost-effective cost-benefit analysis for the patients and the healthcare, and how we deal with the increased costs. Theoretically, precision medicine message is to say, you might pay more for more tests to be done at the beginning, but that will save you money later for the life of the patient, of course. But then the associated cost of pre-hospitalization, retreatment, and all the other associated healthcare costs. And lastly, last but not the least, we need to start looking at innovation related to our own populations. We might find that some mutations are more prevalent in a cancer type that does not have an indication to be treated with X drug. It could be an off-label use. We need to start thinking this way. I'm not sure if we can run clinical trials in the near future, but we should be. Our population looks very different. So this is my reference list if you want to have a look at it. And thank you for your attendance. And just to say, the last thing is, to answer the question, how can we have a regional collaboration? I don't have an answer. And my answer would be, this is an example in Qatar. We might tag on it. We might collaborate on it. But I do believe that we need collaboration. We are the size of the US, and we need to start, with 300, 400 million Arabs, and we need to be studied from the cancer point of view, and we need to tailor our diagnostics and treatments to our population, which I really think from the incidence data looks different. Thank you very much.
Thanks a lot, Dr. Faris, for this really very clear and mainly exciting project. Basically, if I could summarize it, you are looking